Good. So good afternoon, everyone. My name is Tinashe Mutsvangwa. I'm an associate professor in biomedical engineering at the University of Cape Town in South Africa. And my co-presenter is Dr. Celia Cintas, who is a research scientist for IBM Research in Nairobi, Kenya. We'll be talking about machine learning for medical imaging on the African continent. But just to start off, as a disclaimer, Africa is a big continent with a lot of diversity in healthcare, in terms of context, resources, policy, etc. So please accept that our presentation is biased towards our own contexts, which are South Africa for me and East Africa for Celia. And just to reiterate what Karim said, diagnostic imaging is a key component in modern healthcare. It plays a vital role in the diagnosis and prognostication of disease, as well as in monitoring response to treatment. And the number of radiological examinations performed has increased greatly over the past few years, largely due to technological advances in imaging, increased availability of imaging facilities, and of course, the rising demand by both patients and healthcare workers. So what some of you may not know is that Africa has made an immense contribution to the technological advancements of medical imaging. Here is a list of some of the notable innovations and also some research resources that have come online in Africa recently. So the CAT scan, or the computed axial tomographic scan, was theoretically conceived of by a South African physicist, Alan Cormack, who shared the Nobel Prize in Physiology with Godfrey Hounsfield for its invention in 1979. Also, the first full body X-ray scanner, which I'm showing here, was developed in 2002 in South Africa, which was a collaboration between the De Beers Diamond Company and researchers at the University of Cape Town. The Cape University's Body Imaging Center was came about in 2007, and in 2015 they acquired the first research-dedicated MRI facility in Africa. Also recently, the Akeso system, which is shown here, which incorporates a full-field mammography and automated breast ultrasound, was tested in 2014 and CE marked in 2017. So there's a lot of contributions that we can that can be accounted for on the African continent. But while Africa has contributed to radiological imaging innovation, the benefit from this important technology is not always accrued to its inhabitants. Basically, huge disparities exist in the availability of radiological services between the developing and the developed world. An example is the availability of CT units per 1 million people. So Molura et al. In 2013 noted that across Africa, on average, there was 1 CT unit per 1 million people, which you can compare to a country in the global north, such as Denmark, which has 24 CT units. And of course, this availability has changed a little bit, but not enough. As you can see, in a study from 2001 by Gature et al., the number of CT units shown here in red registered in 6 sub-Saharan countries are not much more, there hasn't been much more of an improvement. Furthermore, within these countries, there exist differences between availability in the private and the public sector. And this cuts across all the imaging devices. But here I'm illustrating in yellow the differences between sectors for X-ray. And what you can see is that although the private sector only serves a small fraction of the population in most African countries, there's a disproportionate availability towards of the limited resources in this sector rather than in the public sector. Finally, it's also worth noting that the World Health Organization recommends that 20 X-ray or ultrasound units per 1 million people should be able to serve 90% of a country's population. But we see here in orange that at least 3 of the countries in 2021 were not meeting this recommended amount of devices, at least for X-ray. So what can be done to reduce these disparities? Well, there are a lot of things that can be done from a policy perspective, etc. But from a technology perspective, which I guess a lot of you are interested in, the following 4 have been suggested as ways to improve access to medical imaging in low to medium income countries. These are teleradiology, portable battery powered ultrasound systems, non-radiological imaging, particularly of the type that leverages optical imaging. And this is actually quite fortuitous because in South Africa, so in Africa, we have a large penetration of the smartphone. And last but not least is the use of artificial intelligence, which is the most promising technology of our time. So I'll briefly speak about the examples of the first 3, and then we can spend the rest of this presentation focusing on AI in healthcare generally, and then in medical imaging specifically. So teleradiology is electronic capture, transmission, storage, and retrieval and display of radiological patient images. And it allows for simultaneous sharing of images with other clinicians in other locations. It obviates the needs for losing images and facilitates more interpretation, so remote interpretation and consultation. It's promising because it allows for the sharing of resources and promotes cross-sectorial collaboration. And it has been particularly useful during the COVID pandemic. An example of an architecture of such a system is the one reported by Morgi and colleagues in Kenya, which I'm showing here, which is a system that improved the timeliness for radiologists to access images from remote sites. It enabled the radiologists to manage their time more effectively and alleviated the need for them to shuttle between different facilities, allowing for efficient monitoring and turnaround times for reporting on images. Ultrasound equipment has become compact, portable, of much higher quality, and also the price or the cost is reducing with time. And this has led to the emergence of point-of-care ultrasound, or POCUS, as you might find in the literature sometimes. Now, these devices can be brought to the patient and performed, and the imaging can be performed by a treating clinician in real time, which allows the findings to be directly correlated with the patient's signs and symptoms. Nowadays, we have such devices also leveraging commercial smartphones or tablets for visualization, and through Wi-Fi and cellular communication, you can send the images to the cloud for remote processing, for consultation, etc. So here I'm showing an example of a portable ultrasound being used at Kiboka Hospital, which is a remote understaffed hospital with no imaging facilities and only one local physician on call, and it's in Uganda. Now, the resident physician, in order to use the system, underwent 5 days training and was able to consult with experienced radiologists and cardiologists abroad who were able to visualize both the ultrasound scan and the patient with the use of cellular phones and commercially available video chat software. The augmentation of the physical examination using such a pocket-sized ultrasound machine in rural Uganda has led to significant clinical findings in 70% of cases and to change in case management in 87% of the cases. In 13% of the scanned patients, life-threatening findings were found. So this is quite an interesting benefit from using this technology. And as I said, for the combination of increased use of mobile devices in Africa and increased access to the internet generally, and lack of access to healthcare on the continent provides an opportunity for the implementation of effective mobile health or mHealth tools. So non-radiological imaging, particularly using smartphones, is increasing globally, but has a lot of potential in Africa because of smartphone penetration. For example, here we have a mobile phone-based, there have been reports of mobile phone-based microscopy of sputum smears for diagnosis of active TB. And as reported, and as I'm showing here, this is some work done in my research group on developing a smartphone-based image evaluation for latent TB infection. Now, this tool makes use of a mobile application developed on the Android platform to capture images of an induration, which is basically the bump that forms after a patient is injected with the tuberculin reagent. And the system enables capture of images by the person being screened for latent tuberculosis infection or a community healthcare worker, and reduces the need for the patient to return to a healthcare facility for the induration reading, which usually occurs 42 to 72 hours post-administration of the tuberculin. So now let's move on to the fourth of the areas that I referred to earlier, which is artificial intelligence. So AI is defined as the automation of activities associated with human thinking, such as decision-making, problem-solving, and learning. And of course, AI is fundamentally revolutionizing healthcare generally. And this includes radiology, where it's being incorporated into improving diagnostic image interpretation, prioritizing triage of work lists, quality control, safety monitoring, population health studies. There's a cornucopia of different ways that AI is being leveraged for healthcare. However, as I mentioned earlier, the complexity due to inadequate or absent radiology in resource-poor health institutions in Africa makes the path for us to adopt AI different from what you may find in a high-income nation. So an interesting article by Molura and colleagues advocates for considering the following three for whilst introducing AI to radiology in under-resourced countries. The first is clinical radiological education. Because there's a lack of infrastructure in Africa, which is also mirrored by a lack of expertise. So basically, simply inserting AI into workflows in a resource-poor health institution would not work without radiologists who are educated to interpret the AI outputs, to supervise the AI implementation, and to independently validate AI algorithms on local populations to address issues of generalizability. The second is infrastructure implementation, which is one of the more difficult ones, because for AI in radiology, the infrastructure includes medical imaging hardware, servers, information technology networking, fast internet service, picture archiving and communication systems or PACS, electronic medical records, etc. And so such systems need to be adequately developed before introducing AI on the continent. Last but not least is phased AI introduction. And this includes trying out different algorithms on a variety of platforms across different clinical contexts to assess the AI's accuracy and ease of use. It also includes raising public and patient awareness and piloting AI for patient cases and population health. Now, this is a nice playground that we can all play in. And to me, just respecting these three approaches represents an opportunity for co-creation across different sectors to leverage the AI revolution for improving medical imaging across the continent. So we can all contribute within these sort of three considerations. Nonetheless, as we progress in the medical imaging domain with AI, we need to address and be aware of challenges and concerns when co-creating solutions in the healthcare space. The solutions we develop need to be created through a collaborative approach, including all disciplines from biomedical, medicine, computer science, industry, policymakers, government, etc. We need to be able to address the difficulties in gathering, anonymizing, and annotating large clinical data sets. There's also a need to evaluate aspects of our solutions for issues of privacy, social, cultural context, and potential harm to marginalized communities, amongst others. And finally, during the co-creation step of AI research and development, we need to encourage equitable data sharing practices so that we don't have multiple geographies that have their data accessed and shared, but do not receive the same benefits as the data collectors and owners of the data infrastructures. Just to say that we are not alone in AFRICAI in trying to leverage AI for improving all aspects of life on the continent. Over the years, the African continent has created a great push forward in research, education, and in innovation in the field of machine learning, We have communities such as Deep Learning Indaba and their local chapters, Masakane, Data Science Africa, Africa Archive, H3A, Bionet, AARS, and more. And they've all contributed to a growing network and knowledge base of AI and its applications. And there now exists a very rich and I would say a diverse space for intra-continental collaboration. So we encourage you to look up all these communities which for many of them have representation in a lot of African countries. And finally, for those who are entrepreneurs amongst you, please note that there's a lot of innovation taking place on the continent and being commercialized. There's innovation in the space of device manufacture, as with Lodox, the full body X-ray company I mentioned earlier, and Cape Ray, that produces an integrated mammography device. There's innovation in the area of teleradiology, as with AccuRead Radiology in Nigeria. There is also I think it's called Urology in Egypt, which also is in the space of teleradiology. In addition, of course, there's a growing amount of innovation in leveraging AI for image-based diagnosis, as with Algorithmi in Nigeria and Mino Health in Ghana. Now let's hear from Dr. Cintas, who will showcase some exciting use cases of AI in healthcare generally, and in imaging in particular in East Africa and South Africa.
Thank you, Tinashe. Let me share my screen. Can you see the full presentation mode?
Yes, yeah.
Excellent. Thank you, Tinashe. So now I would like to share some examples of both digital healthcare in Southern and Eastern Africa. We can find common challenges in the healthcare system and the policy-making space in these two regions, such as, for example, the burden of communicable diseases such as HIV, AIDS, and TB, and non-communicable like hypertension, cardiovascular diseases, diabetes, cancer, as well as injury and trauma. Furthermore, we see the disparities and the scarcity of healthcare providers as their geographical distribution, similarly to the equipment distribution that Tinashe mentioned a few minutes ago. And lastly, what we see is a need to define and better understand policies to improve MNCH outcomes. So given this set of challenges, of course, among many others, we are biased to our working teams. We see the improvement of quality of care and care continuity as key research topics. We also need to look on how to make sure that the solutions that we provide are trusted by the community. How can we promote data ownership by the users, physicians, and patients, as well as guarantee privacy settings, just as Tinashe mentioned in the challenges. Lastly, most of us will be working in a resource-constrained setting that we usually navigate in this health domain. So we need to be able to provide imaging solutions so health providers can access to enhance image information at a lower cost. So I wanted to show some examples of research done here at the Kenya Lab in cooperation with healthcare experts and policymakers around these topics. So for example, you can see Aisha's Walcott team assessing the perspective of the stakeholders around the management of hypertension in Kenyan private health sector. And they provide some recommendations on how to design and develop care continuity digital health solutions. On the other side, you can see Eric Odor team that analyzed the context for tech solutions for quality of care for hypertension patients with HIV. This gives you an example on management of comorbidities and patient quality. On the other side, we also have examples on how can we use machine learning techniques to provide information to policymakers. For example, in the space of family planning, we studied contraceptive discontinuation and uptake patterns in subpopulation levels. William Ogallo and Skylar team work with domain experts and policymakers for MNCH, studying ways to better understand neonatal mortality factors. And Seku also works with reinforcement learning and other methodologies for orchestration of set of interventions for malaria policymaking, but also for other disease modeling. These are some examples of studies around healthcare and machine learning using health population surveys or electronic health records, among many others, that could be a complement or overlap with also medical imaging solutions. So now we're gonna show some examples from both Tinashe and myself's team, specifically related to machine learning and medical imaging. So one research project we can see is on the bottom left. It's a framework to be able to provide high quality 3D information from X-ray views. For this project, they use something called statistical shape models to adjust the 3D shape based on the information of the X-ray views. So this type of reconstruction can be used to aid in multiple clinical tasks such as surgical planning, postoperative evaluation, and you are avoiding higher risk, higher costs and relatively greater patient irradiation associated to the 3D modalities that we can see with computed tomography. The team also works on solutions to be able to pair multimodal imaging for a given patient. So they propose generative process for synthesizing valid, realistic, and pair CTs and MR image volumes. So all these type of, or following these streamlines, this work was published also at MICAI 2020 that I think Karim showed on the first slides. On the other hand, I will talk a little bit while we are working on machine learning at dermatology here at the Nairobi lab. So as you can imagine, as in other medical fields, we can find disparities in the dermatology space. So for example, in African American populations, melanoma is often diagnosed at an advanced stage. And for ALM, the survival rates are 5% higher for Caucasian populations compared to the African Americans. In these pandemic COVID times, dermatologists started gathering a registry to be able to catalog the skin manifestations of the disease. But currently they reported a low amount of samples for African and Latin patients. So this paucity of images on skin manifestations for COVID for patients with darker skin tones is posing a problem because it makes the identification of COVID based on cutaneous manifestation more difficult for both professional dermatologists and the common public. Of course, these disparities are not new, and there is people in healthcare working on educational materials such as Mind the Gap from Malone Mukwende that teaches how to report clinical signs in darker skin tones. But we need to think that when we are deciding or co-creating these machine learning solutions in medical imaging, we want to ensure that these and of course all the disparities are not translated and amplified in our solutions. So I will show you 3 streams that we have inside machine learning and dermatology. They were done by a subgroup of these amazing researchers, masters, PhD students, dermatologists from multiple institutions that you can see the references for each team. So first example was led by Tim and Newton from Carling Mellon, Rwanda. They spent a few months doing an internship at the Kenya lab. And this is the work that was presented at AFRICAI 2020. So they proposed a framework to be able to automatically stratify the classification outcome by skin tone. Of course, for that, we need to be able to extract the pixels from non-disease area and be able to estimate the tone in an automatic way. After, we can do some stratification to get the metrics out of the model. So this had multiple, for the segmentation model, there was a mascara and CNN that was tuned for skin tones. Multiple data sets common in dermatology were used. And after we have the pixels from the non-disease area, we have a skin tone estimation to be able to bin these results. So in this work, they show that there is an underrepresentation of darker skin tones in common use dermatology data sets in machine learning challenges and benchmarks. So this is the type of information that we want to know when we share our models and we want to test it in real life. We need to make sure that the population matches to whatever we want to make the deploying. So after AFRICAI paper was out, we were approached by dermatologists at Stanford that they were wondering if we can apply a similar pipeline to evaluate educational materials that are used to train the professional dermatologists. So this would be an automatic way to quantify the representation of different skin tones and their condition manifestations shown to professionals during their education or training. Shocking or similarly to the machine learning example, the preliminary results that we ran across multiple dermatology textbooks used in medicine school for validation, they are showing an underrepresentation of darker skin tones equal to 10 or less % of the examples that are shown to professionals. So for this work, we are currently developing a pilot. So any professional can upload their slides, books, materials, papers, and they have a representation analysis of the show that they are working or they are sharing with their colleagues. The last branch of work is around how to make our machine learning models robust. So usually these models are assuming ideal conditions and that the tests or the clinical data that are taking comes from the same distribution of the training. However, this of course is not satisfied in most of the real world applications. So for example, in a clinical setting, we can have different hardware devices taking the pictures. We can have different setup, context, lighting, diverse patient populations with different or unknown conditions. So this work was presented a few weeks ago on ISP and basically was trying to show a method to be able to detect this type of out of distribution samples after the model is already trained and working out. The technique is called substance scanning, and the core developers, researchers are sitting here at the Nairobi lab. So we are pretty proud of that. And of course, since the beginning, not only we measure the basic metrics that we always see for accuracy or performance, but we also stratify by the skin tones. And of course, on the OOD detection, we also see an stability when we are looking to darker skin tones. And this could be going back to, or partially because the network that it was trained on was again data sets that don't contain samples for darker skin tones. So before closing, we wanted to share some exciting opportunities that were recently funded. The Computational Omics and Biomedical Informatics program will provide interdisciplinary training opportunities for PhD students and faculty members around fundamentals on data science, computational omics, imaging, machine learning for biomedical, and so on. So if you're interested in this, please do ask Tinashe on more information about this program. So thank you again for your time. So in this presentation, we wanted to share an introduction to the current state of the field in some parts of the continent and examples of research that is being developed here and across at least Southern and East Africa. Now we really want to hear your thoughts on the topic. What exciting projects are you working in your country? What challenges are you facing on the space? If you are interested in presenting your work on the next seminary, please reach out. You can contact us via the link. And then if you scan the QR code, there is a link for a live poll when you can answer these questions and we will gather together the information. Thank you very much. Back to you, Karim.